The problem is you do see a lot of antisocial people succeed. Loneliness is as big a risk factor for ill health and death.
We live inside our heads.
You go cold turkey, you go into withdrawal.
There is a lot of value in the stuff that we struggle with.
Better Thinking. Conversations with experts exploring all things psychology. Welcome back to Better Thinking. My name's Nesh Nikolic, and my guest today is Associate Professor Lucette Cysique, a neuropsychologist researcher whose interests lie in modelling neurocognitive and brain changes based on chronic infectious conditions such as HIV infection and COVID-19. Lucette completed her neuropsychology undergraduate and graduate degrees in France and the UK, her neuropsychology PhD in Australia, and her neuropsychology and neuroimaging postdocs in the US and Australia. Currently, Lucette is a senior lecturer at UNSW School of Psychology, and she also leads and co-leads NeuroHIV trials nationally and internationally. In addition, Lucette is chair of the NeuroCOVID International Neuropsychological Society Special Interest Group. I'm pleased to be able to share with you today my conversation with Lucette, looking at the need for understanding post-viral syndromes and how doing so would help the better longer-term outcomes for individuals and the community as a whole. There's a bit of a cultural shift that needs to occur, and hence why I think this conversation is so important. Enjoy. Lucette, a big thank you for coming onto the show today. I'm really excited about talking about your space around mild cognitive deficits, or at least being able to identify them, potentially detect them early, and how they can be a sign of, some quite serious infectious diseases like HIV and COVID. I think this is not an area that gets too much attention, yet I think the implications can be quite significant and enormous. So real appreciation for you coming onto the show today.
Thank you very much. My pleasure.
I'm actually excited to start off with how you got into this space. This is quite a niche space, so maybe you could talk me through that to start off.
Yeah, that's a very good question. Yeah.
I'll go from there.
Well, as my accent probably betrays, I'm not Australian born. I was born in France, and I got interested into neuropsychology and neuroscience as part of my psychology research, and then eventually I did some research in Alzheimer's disease. And I have to say that at the time I was quite young. I was in my early 20s. At the time, working in Alzheimer's disease for a young person, a young neuropsychologist, was a little bit daunting. There was, no hope for treatment. I mean, there was a treatment, but it was not working, so it was quite challenging. And I have to say, so what's good is that there's now hope. There's new treatment coming on the way, so that's great. But that's like that's gonna betray my age. It's gonna be like 30 years ago, 20 years ago, 25 years ago. Anyway, so I was really interested in brain science, in neuropsychology, and the clinical aspect, and I was interested in aging, but at the same time, being myself coming from a minority and be interested in sort of other way of thinking about the brain, I ended up being interested in the effect of HIV on the brain. And I met a neuropsychologist at the time in Paris who was working with Jacques Gano, actually, I think his name was. She, I forgot her name, Sandra. That's terrible that I forgot her name. It will come back. Anyway, so she introduced me to the work, and seeing some patient Kremlin-Bicêtre in Paris, and I got interested right away because of the patient population. And at the time as well, I was in connection with an activist from ACT UP, actually, in Paris, who was worried about, this aspect of health in people with HIV. People were he was more concerned about the issue of mental health. But when we met the neurologist Gano and Kamla Bisset, he was more interested in a neurological aspect. And he's actually quite well known for some of the research in some changes due to the white matter change in the brain in HIV. Anyway, so meeting all those people, I felt that it was, the right connection for me to bring my expertise in brain science and the idea of working in a population that was a minority. I was interested in that, a younger population, and yet to be able to make some changes, because it was at the time where the new treatment were arriving. So there was hope that when people could be detected early, they could get treated and they could get better quite rapidly. And it was actually quite amazing to see people, really presenting with dementia and coming out from it. It was actually quite of a unique experience as a young neuropsychologist to experience that. And so after that, I decided that I would come to Australia, do my PhD, because my partner is Australian. So I thought, we wanted to leave Paris at the time, and we wanted to, we had lived in Paris for quite a long time, so we wanted to have our life somewhere else. And so I did my PhD with Professor Brew at St. Vincent's Hospital, and Professor Paul Maroff, who was a neuropsychologist who had worked in HIV as well at the time. And that's how I got into that, and never looked back really. So it's a funny story, because I didn't know anyone coming from Paris. I didn't know anyone in Australia, so I contacted Professor David Cooper, who was the head of the Kirby Institute, where I'm based now, and he said, "Oh, I'm not working on the neurology. You need to contact Professor Brosbrough." And so I contacted Professor Brosbrough, and he was interested right away. And that was the beginning of an amazing collaboration.
It's amazing, and welcome to Oz. I hope you've enjoyed
Well, I've been
it.
here
Clearly
since
have.
2001, so I'm partly Australian for sure.
You're Aussie as it gets. Absolutely.
Yeah, that's it. I'm
Absolutely.
definitely partly Aussie, because when I go back to France, I feel that I'm a bit Aussie for sure.
And tell me about this space around mild cognitive deficits. I imagine this is such a difficult area to work in that so many people would report some type of mild cognitive deficit.
Yeah.
The importance of early
yeah.
detection is incredible, in terms of treatment, and I'm sure that in terms of outcomes,
Exactly.
everything is always about early intervention.
Yeah.
So maybe you
Exactly.
can just talk me through a little bit about what do mild cognitive deficits look like, at least in your world, and what you're looking for, and whether it's anything different with HIV or COVID or other conditions as well.
Yeah. Well, if you don't mind, I'll just go back to that story, leaving France. I was working in a INSERM unit who was specialized in brain aging. And I was also working as a neuropsychologist in a Parisian hospital in the south of Paris, in the 14th arrondissement. And in that, in these two positions, I met a lady that has marked me forever. This story, because I was quite young. I was again in my early 20s, and so I had her as a control participant in one of my research at the time. And she came as she was extremely anxious, and she did all the tests, and she said to me, "Do you think I've got dementia? Because my mother had it, and I really want to know ahead of time." And so I remember looking at the test at the time, there was nothing really that was, suggestive yet of anything significant. Some maybe subtle change in the behavior, maybe. But then 2 or 3 years later, when I was working in the hospital, she came as a patient, and she was already extremely, deteriorated. And she said to me, she recognized me, and she said, "Why you didn't tell me?" And that has stuck with me, that story, that was stuck with me. So I guess maybe there's sometime in the way of me trying to not ignore, early signs. There's maybe that story that's there as well. Because it was very emotionally something strong when you leave when you're quite young, and that I remember forever. And she was already so deteriorated, but she still remembered me. And so I guess when I entered HIV, the difference was that we could detect things and we could treat people. When I say we, so I'm a neuropsychologist, I don't prescribe the medication, but we work in concert. So we detect the level of deficits and, the pattern of deficits. And then the neurologists, with all their other examination, put a diagnosis. But the idea is we need to detect early, because then we knew that when people have had HIV for a long time, for example, and if they had starting to have cognitive impairment, the longer they've had those deficits without treatment, and the less reversible it would be. And I worked while working postgrad at St. Vincent's Hospital during my PhD. I did some research on people like that who had dementia, and they've with the treatment, things stabilized to a certain extent, but the one who had been off treatment and the most demented for a long time, I never fully recovered as well. So that's why I think the preventative aspect for me and the detection of early deficits is really important. And then then working with patient and the community, and I'm still doing that today. They are a part of the community who's really advocating for early detection and trying to find solution as early as possible. There is another part of the community who's really scared about the topic, and maybe is a bit less willing to confront things frontally. But so I work with one particular community activist in the US, Jules Levin. He's been doing that for many years, and he's the head of NATAP, which is the National AIDS Treatment Advocacy Program, I think, in the US. And so with him, I guess, and other colleagues, we've done that international group, and that's what we're pushing. We're pushing for early detection, early management, and we've been pushing that for many years. And it's interesting because while we've been pushing for that, the Alzheimer field and the overall dementia has caught up, and they're really promoting this now. Why? It's because in the last 20 years of neuroscientific research, one of the main findings is that anything that has to do with progressive neurodegenerative diseases, in old age, we know that they do start way earlier in life, and 20, sometimes even 30 years before the actual sign appear. And so with this in mind, we even if the context in HIV and COVID is a bit different, with this in mind, the field of neuropsychology and neuroscience has been more and more able to detect things early and the earliest. And so there's an ethical question then. At what time do you actually, probably tell the patient, you are at risk of cognitive impairment, or there's you have some mild deficits, or most often actually people do realize that they have some deficit, but not all people do. It depends on many factors, but the I guess the reticence, is that an English word or a French word, this one, the difficulty of the medical community, and I was talking with a young doctor about that the other day, to diagnose early and early as possible is when there's no treatment, they feel like it's not the appropriate things to do. And they're correct, but only to a certain extent. So when the research that has been done now in dementia that has actually surpassed us in HIV, we were ahead, and we I think we're a bit behind now. But the research that shows that when you detect patient early, first, most of them want to know, maybe not everybody, but most people want to know, so that they can manage the situation as best as possible. And the management is not only a medication, it's a cross-disciplinary approach, where, like a bit like a geriatric approach, where depending on the person's difficulty, there's going to be, some psychological helps, some rehabilitation help of different kind, some social help, etc., etc. So it's not going to cure things, but it's going to cushion and support, people's life and quality of life, and also it's going to help the carers and the family, the loved one around to understand what's going on as well. So there's going to be this kind of adaptation to, or what am I able to do? Like in the case of any mild disability, really, it's not, it's my life is not over. It's not what we're talking about. What we're talking about is adapting to your new level of functioning. And I think it's not something that infectious disease physicians have been trained for. They've been trying to treat a disease that's acute, like an acute infection. And like the way they responded during the pandemic, the COVID pandemic, was fantastic. But that framework does not work for chronic neurological diseases. For chronic neurological disease, we need an early approach, as detection as early as possible. If there's treatment down the line, that's great as well. Like hopefully there's going to be for Alzheimer's soon. But those treatment in Alzheimer, more and more, there's the sort of already, we can already see that they have to be initiated early to, if not, stop, at least delay, the neurodegeneration. Everybody knows that after a certain level of neurodegeneration, there is no coming back, unfortunately. So in HIV and COVID and all the infectious diseases, we're not talking about neurodegeneration. It's just different. It's probably going to be more like neuroinflammation. But again, the level of deficit that we detect is mild. What I mean by that is that people still have the capacity to think about complex things. The reasoning is intact. The capacity to make decision is still okay, and a lot of the hard-learned, capacities are still there. But anything that has to be about multitasking, things that will involve, a high level of cognitive effort, learning new information that's quite complex, then that's going to be challenging, more or less challenging. And so the doctors, sometimes the medical doctors, when they see a patient like that, they're like, oh, you can still do this, all the basics in your everyday life, so they think they're fine. But there is no reason to intervene at this level because the person is still functioning fairly well. But what we see, and we've seen it during COVID, is that when people are high functioning and they drop, by maybe half a standard deviation on some of the tests we do, actually they can't actually complete with efficiency their level of activity. And for some of them, it's more than that, but that's where it starts. And that can be extremely distressing for some people. It depends on the basic functioning, the baseline functioning that people had. But if someone, let's just say, I guess one of the best examples is people who fly planes, the pilots. Those people get tested all the time. Okay, so if they develop this level of mild deficit, they wouldn't be able to fly. That would be detected on the test that they done. So that's the level of functioning we're talking about. It's really high, complex tasks that are going to be affected. With long COVID, there's also and to some extent HIV, there's also the issue of the fatigue. So that's something else. And it's mental fatigue. So it's not only whether you're able to do a task as fast as you can do it, but once you've done it, once you've put an effort into it, then you're extremely fatigued once you're finished, and even worse the day after. So that's another symptom. But so
Lucette, how predictive are these markers for dementia in terms of being able to detect a change and then be confident in that it is associated with a dementia? I imagine it's probably a bit different with HIV. There's probably a simpler pathology that test that can go out and say yes or no or whatever it might be, or maybe with COVID as well. And please correct me if I'm wrong here as well. But is there are there strong markers for this now that have been developed, rather than the haziness about saying, oh, I'm not quite sure, I do get a bit forgetful or sometimes disorientated or whatever it might be. We can all certainly see it when it's in its severe chronic phase, but there's, as you say, the importance of finding it early.
Yeah. So So maybe what I didn't clarify is that what we worried a little bit in HIV at the moment, and in other area or similar area would be COVID as well, is that there's a part of the population who, when they get HIV or they've lived with HIV for a long time, same with COVID, people are also aging at the same time. And it's actually very difficult to distinguish normal aging from abnormal aging in people with chronic conditions. It's actually much harder than what has just been recently developed for Alzheimer's disease, I guess. So with Alzheimer's disease, there's some blood tests that are coming up to detect amyloid in the blood and in the brain. But so how can I explain that? I think so. It's important to distinguish. That's what's difficult in our field, is that the disease. What's expressed as the disease, depending on people's age, is going to be different. So once we have someone who's lived with HIV for, let's say, 40 years and start to reach the 70s, we're not talking about the same thing as developing a bit of mild cognitive impairment when you're in your 30s with the same condition.
Sure.
Things are quite different. And so I think what we're trying in our field there with that group that I've put together, what we're trying to bring is some of the knowledge from the psychology of aging, and also the neuropsychology of aging and the dementia field, into the knowledge of how to deal with early cognitive impairment in people who are aging with HIV or with long COVID, for example. So that's what we're trying to do. But when we can use some of that knowledge for people who are younger, but the truth is that it's not the same, right?
Sure.
So what the original question that you've asked? Sorry,
the question was about how predictive the markers are in terms of.
So it depends which marker you are talking about, but so the neuropsychology field found, it's at least 30 years ago, that there was some studies showing that new learning of information was predictive of cognitive decline in old age. So that has been done, in the 90s, and that for some reason those findings have always been, under recognized to some extent, because I think the issue with neuropsychological tests is that they are very sensitive actually to all kinds of things. They're not only sensitive to the actual deficits that you're interested in, they're going to be sensitive to, age first, your level of education. Women usually have better memory than men, especially in older age. There's some cultural factors that will impact the test results. So they have to be handled quite carefully, those tests. And so while those findings are interesting, they do not have the sort of a solid aspect of a biological marker, you've got a certain level of amyloid, then this means, although, even with amyloid, actually, you can have a certain level of amyloid and function fairly well. So it's not always black and white there either, but it's even more complex with neuropsychological aspect. So what's interesting about neuropsychological aspect is that it does reflect people's current cognitive functioning, though. So it's part of the puzzle. So because some people today would want those biological markers to basically be at the forefront and everything else come next. But the truth is that when it's about the brain, it's always more complex.
Yeah.
So you need
pattern recognition.
You need to know if people have a certain level of biomarker that's abnormal. But the truth is that you need also to examine the cognitive functioning to see if there's some level of change as well. So it kind of goes together. So how predictive are the markers? Well, let's just say there are some genetic markers for cognitive decline, and there are some, as I said, neuropsychological markers, and when they do all come together, they are quite predictive, actually. Unfortunately for, people who develop the disease, but they are quite predictive. And that's why the pharmaceutical, company that are developing tests now for that are developing medication for dementia actually are targeting people earlier and earlier because they know that those tests are actually quite predictive.
Mm-hmm. And what are you seeing as being the most prevalent signs when you're doing this research? Obviously, you mentioned that the early studies looked at, difficulties with new learning are quite predictive. Where is the science at the moment? What sort of markers do you look for?
So you mean in terms of neuropsychological changes?
Yeah.
Yeah. Well, so as I said, there are some criteria that have been put out there to look at what's called subjective cognitive decline. So it involves not only, objective performance on some cognitive tests, but it involves also how people themselves describe their cognitive difficulties as well. And so there's even some evidence that we can use what's called the practice effect as an outcome to predict if people are going to have some sort of to use as a prediction of how much they're going to be able to learn in the future. But I'm just we're not in a situation where there's a one test that answers all the questions. That's what I'm trying to say. What I'm trying to say is that it's really a cross-disciplinary effort. It's the same with neuroimaging. So neuroimaging as well come into the foray there. So there are some changes in the brain that we know that are going to be predictive of some neurodegenerative changes. But the truth is that it's really when all of that is brought together that a clearer picture emerges. Yeah.
And is there obviously COVID was a huge worldwide phenomena experience. Was there a body of work that came out of this? Because we certainly heard a lot of people, and I certainly felt it when I became unwell on the physical front. I was astonished about how my breathing was affected. I would walk probably less than 100 meters and I'd be out of breath, and I can't recall any illness that knocks me about that way. I've certainly heard of a lot of people talk about it, long COVID and how people feel foggy in the brain and all sorts of things. Has there been substantial research in that space, being maybe an area that so much data has been collected or still working through the masses, I'm assuming?
Yeah, so it's really a hot topic. So there's a huge amount of research. It's massive. Every time I look at this research, about neurological changes and cognitive changes, brain changes in COVID, there's new papers all the time. It's enormous. Most of it is not from Australia. Most of it comes from overseas. But still, we have a place in Australia. I guess we're catching up. We've done some work, here at St. Vincent's and at the Kirby. But basically, so I was trying to get at earlier. I'm not sure if I was really clear. So I think COVID, sorry, the COVID epidemic was a revelator. So it was a revelator in the sense that people have always sort of thought of infectious disease as an acute condition. In the case of COVID, for example, that was respiratory. But I think it put the emphasis on what's called post-viral syndrome and also post-infective syndrome. Actually, there's a whole area of study on this that has been sometimes is still a bit ignored nowadays, that framework. And that framework is very important. It's been recognized for quite a long time. And it actually fits really, really well the field of long COVID. So there we know that after a certain viral infection, we know that people can develop a post-viral syndrome. So it's the difference with the virus is that some viruses are directly neurotropic or neurotoxic as well. So they're going to really have a deleterious neurological effect, and it's very obvious. But for a lot of other viruses and viruses that present as respiratory viruses, like COVID, the changes that are created cognitively post-viral are actually mild cognitive changes. People do not get dementia. So that's where it kind of links back with what I was trying to say earlier, is that, and we know that most people who develop long COVID are actually between 20 and 50 years of age. And so so we're not talking about an older age situation, although there's some research there as well. But so what I'm trying to say is that all this knowledge that we have about detecting cognitive deficit early applies to post-viral syndromes, because we know how to detect them best, and we know we can use the framework of post-infective fatigue research to actually try to understand how much the fatigue contribute to the issue, how much mental health contribute to the issue, or do not, etc., etc. And so I think the COVID and the story of long COVID has been a big revelator, in the sense that, actually, this field should not be a niche area. It's actually, a major health issue, as much as cardiovascular disease or, I don't know, renal or cancer. Because when you look at the impact of long COVID in terms of, economic impact, some people put it as high as cardiovascular disease, for example. Maybe not as much, but I mean, not as high as in the long term, but in the last few years of the pandemic, that had have a massive impact. And so some countries have responded better than others. And the UK, because I'm doing some research on this at the moment, the UK is responding absolutely amazingly, despite all what we can hear about the UK in terms of their health care over there. Not only they're responding amazingly in terms of the NHS, in terms of the way they've created some clinics all over the country for long COVID, but they've also reacted really well in terms of their research response. And they've created, very large cohort to understand what is long COVID, how often it happens, etc., etc., etc. We're not yet there in Australia. We've done some work, but we're not yet there. But I think one of the major revelation of this situation is that what has been called brain fog and long COVID, a major component of it is cognitive changes, and they are those mild cognitive changes that are very difficult to detect. Okay, because they're difficult to detect in the sense that people, again, people are, if they go and see the doctors, they don't present as demented, they don't present as very impaired, and they're going to complain of mild changes that are not very, that do not seem like dramatically, impacting on their life, but they do describe those changes, and they can't go to work normally, they can't concentrate as much. I've got a colleague, their difficulty was not that they couldn't go to work. No, their difficulty was they couldn't write their presentation as fast as usual, and there was this kind of, added fatigue and difficulty in doing it. So we're talking really about subtle changes sometimes. But what I want to, I guess, the message to medical doctors here is that myself, I've done 30 years of neuropsychology. When I see this patient, and I talk to them face to face like this, I cannot detect anything like that. I have to do some tests to be able to detect. And even sometimes the tests themselves, depending on how high functioning are the people, it's actually very difficult to detect the changes as well. We have to put them in situations that are extremely demanding for it to show. Because I think sometimes the cognitive assessment gives people a kind of support situation, and so they're still able to perform quite well. So I'm trying at the moment to remove that, to create some new test paradigm where I remove that support, and people have to fend for themselves like they would be in the real world. Anyway, so I think that is changing things, hopefully, because there's a lot of research being done. And the other aspect is there's a lot of biomarker research being done in terms of neuroimaging, biological marker, etc. And we do find some abnormalities. So there's also the idea that, well, it's actually not in people's head. there's really something going on,
Yeah.
because the issue with those patients is that when they go and see their doctors, they do get the feedback that it's all in their head and it's a psychological issue, not, and we know that it's not exactly correct, or at least we know that some of the self-perception of cognitive change is also affected as well in some patient, right? Anyway, so to answer to your question, yes, there is a huge amount of research of long COVID. It's massive. There are some very, very large studies being conducted in the US, and those studies have already created, some research trial, how to intervene and respond, both of them, like cognitive intervention and those kind of things, but also medication. So it's actually a massive area of research. It's enormous at the moment. Yeah.
It's fascinating because it poses that question of these post-viral syndromes, the opportunity to go out and support people. And you mentioned that the UK is responding really well to long COVID against a medical system or a system that is going to struggle to detect it, and that might be because not that the opportunity isn't highly valuable, but in terms of it is so mild that it is often misinterpreted as it's not very significant. It might be just you're having an off day. We all feel a bit foggy at times, so all of this goes under the radar against sending someone for a test. And I think that's probably a great challenge for, I think, what GPs do. They're absolutely amazing and extraordinary people and such incredible professionals. At the same time, they've always got those very challenging decisions to make about when do I go and send a patient to have an examination, a test, how much pressure is already in the system for these types of tests, how many people are there out there doing it, versus saying, my experience tells me that most of these things are, nothing, air quotes, so to speak.
So I guess there's two, three things that I should have said. So first is that the majority of people who get COVID recover. That's a fact, I mean, so the people who actually develop long COVID is a minority. It's actually a true minority, it's not the majority, but it's big enough because so many people have had COVID, so it's big enough that it will put pressure on the health system. The second thing is that the GP actually do recognize those patients, because the one that I know, talk to, they do see it, and what they want help. What they want is they want help on how to manage those patients. That's what they want. And the third thing that I wanted to say is beside the help that the GP want, there's also existing treatment that are available. So they're not medical treatment, but they are different strategy that have been developed for chronic fatigue syndrome, for example, including psychological sort of intervention of different kind that do exist, that will actually work and help people. And I should say also, that's the one that I wanted to say, is that even including among people who will develop long COVID across a few months, the majority as well recover. So in other words, what's needed is a support across the period when people are feeling unwell, because the majority do recover as well, spontaneously.
And can you say a little bit about what the UK is doing? You mentioned that they've responded well, that they've opened up particular clinics to support not only patients, but I assume support GPs. They're looking for assistance and support as to how to help their patients.
Yeah. So as part of my current position here at the Kirby Institute, I'm employed as by the APRISE, the APRISE consortium. So, and I will have to go like this. I just have to tap APRISE because I don't want to say something wrong. So the APRISE It's just this acronym that's like, the Australian Partnership for Preparedness Research on Infectious Disease Emergencies, which is at the Doherty Institute in Melbourne. So this consortium has also a long COVID initiative, which I'm one of the leader besides Professor Lena Sensi and Professor Andrew Lloyd. And our job is to conduct a new prospective study about better understanding long COVID, but also better understand what Australia has done as an early response. And so doing that job, I went to check what other country had done. So I went to check what UK had done, Canada, and the US. And the UK had the best responses in the sense that they developed early services for long COVID. And they've listed all of that on, NHS. They've got a list of clinics all over the country, and they've also put, how do you say, educational tools for both the community and the doctors on how to manage long COVID. And they've also, beside the WHO created a definition of long COVID, the US CDC, but the UK did as well. So they've also developed their own, which creates some problem actually because everybody's using a bit different things. But they've done that too. And then the next step that they've done, they've given money quite early on to determine what are the health consequence of COVID, and doing that, then they transform more and more into what is long COVID, what is the biology of long COVID, how much long COVID do we have really, the different types of long COVID. Some people is more cardiac, some people is more brain, some people is more respiratory, etc. And so they've put some 50 million pounds of dollars into funding about 19 major cohorts across the UK. And they've done that in a timely fashion. So they've started to do it early in 2020 onwards. So they have data on the early people who were a victim of the Alpha and Delta variant, because it is correct that the Omicron variant are less severe. But and then there's been the vaccinations as well. So they've kind of had a well-rounded response, and they've also done a lot of effort to also follow sort of the WHO guideline in the sense of sharing data and tracking the data nationally to national coordinated response to inform WHO about what they find. So that's been pretty amazing. So we're trying to follow in that track here with the Uprise by mapping everything that has happened early in the pandemic, and we have our own prospective cohort where we're going to try to better understand what long COVID is. I think where we are ahead compared to other countries, that we work with specialists of post-viral syndrome that have been working on this for 40 years. So my current boss, Professor Andrew Lloyd, and that gives us a really, really nice, strict framework to really concentrate on the people who actually have the condition. Okay, because one of the issues with long COVID and all post-viral syndrome is to try to, and same with mild cognitive impairment related to HIV, is to really being able to identify, the people who actually have the condition versus have other problems. And so I remember talking with community, members about this issue, and some of them were a little bit upset because they were saying, well, if the definition is too strict, then you're going to exclude too many people. So it's always a balancing act. But what I was saying is that it's also important to concentrate on the people who have actually the condition, because the people who have something else actually need to be sent to the other part of the care system where they're going to be treated for what actually they have. So it's not going to be how can I explain? It's not going to be an issue for the patient to be seen for the condition that they actually have versus they don't have. It's actually going to be beneficial for everybody there. But to say that we need to develop a better response to long COVID here in Australia, yes, we do. It's each time I participate to like a occasion like this one, or when I'm doing a talk, is to say that with post-viral syndromes and brain issues, they should not come as an afterthought. It's very likely that cognitive changes will happen with post-virally. Not they're much less likely when people have had the flu, but it's also possible. So when there is something that is impacting as COVID, we should think, or the neurology and the brain aspect should be part of the response. It shouldn't come after, if you want.
It's interesting because we've all felt it in one way or another. And we clearly understand that, obviously, with particular conditions like cardiac surgeries and the like, there's always these big booklets that go out and say you're likely to experience changes in emotional regulation, sometimes even some personality things in terms of the way you tolerate changes in your life. There could be some memory difficulties, etc., etc. But we don't have these big booklets in other areas of saying, when there's a post-viral infection, what are you likely to not likely, but certainly likely initially, and then maybe subsequently, because as you say, most people still fully recover, but some don't. And knowing that there is another experience to it means that we might be able to get that early intervention. Some of it being a lot of things that we can potentially do for ourselves. Some of it might be medical related, others might be general health.
Yeah, exactly. So if I can jump on what you said, that's exactly what we're trying to do with that group, that international group. So we have a group of scientists who, with community activists and doctors, and we've come together from all over the world. And we all worked in HIV for many, many years. And the idea is to develop guidelines for what happened, what should you do, so health literacy for the community, health literacy for the doctors as well. And rather than cognitive deficits or mild cognitive deficits in particular, because I think it's the emphasis it's not dementia, so that's why sometimes it's under-recognized, but they're also important. So, and they're going to be more frequent in a way. So I have a guideline for the doctors and for the community in using community words, that can talk to a wide range of people. How do you deal with that? What do you do? How do you talk? So, for example, in the US as well, they've done great stuff on their website. NIH and CDC, they have actually guidelines for the patient to say, how do you talk about it to your doctors? How do you mention the problem? What kind of information do you bring to your visit to the doctors? So that's what we want to do. We want to do in the context of HIV and aging, because a lot of people are worried about the question of HIV aging. And it's a bit specific, this question, because the people who had HIV now in the 80s are the first generation to get old with HIV. So it's a new situation. That has never happened before. So sometimes us people from the neuro field, we've seen as a bit fear mongers, or people who bring the bad news, in HIV, because people say, well, HIV is a treated condition, people are not doing so bad, etc. And we want to say, well, there's good knowledge that when people have had chronic condition, whatever they are, unfortunately, they're more at risk for cognitive decline in old age. And with HIV, the issue is because it's the first generation of people going to get old with HIV, we don't know how it's going to look. We have no idea because it's new. So we're trying to just be on the alert, and we're not trying to be too pessimistic in the sense that, okay, if you had HIV, then make sure you're going to have dementia. That's not the case. That's not what we find, actually. But we want to also make sure that there's enough knowledge on what people are experiencing, so that we impact on policy and actually the health services that are provided. Because the feedback that we have from quite a few people in the community is that their issue is under-recognized, and when they go to their doctors, they get ignored. Because again, they think there's nothing to do about it, but there are many things. So neuropsychologists are the first they're not the only one, but the neuropsychologists are the first person to see, so that and the neurologists as well, they're the first person to initiate this sort of cross-disciplinary intervention. And I'd say, in an ideal world, the best person would be to see a geriatrician. But geriatrician only comes into care when people are fairly old. So it's often 80 plus.
Yeah.
The issue with HIV is that the aging that people experience with HIV is a little bit premature. So for quite a few of them, I think that geriatric care should start from, at least, I mean, ideally 60 plus, but if it'd be already 70 plus, that'd be already good.
Mm-hmm. What do you see as being the challenges of a cultural shift? I call it a cultural shift because it seems like it requires people to think differently,
Yep.
Whether it's GPs or whether it's patients themselves, whether it's, the community, medicine. What do you see is the challenge in starting to think in this way where, we're really looking early detection, and spending that energy to do so, knowing that there's quite a considerate benefit. We often see it early intervention with children, but we don't think in the same way when they're quite mild and they're post-viral. We see a similar problem, I think, with post-concussive syndrome as well.
Yes.
Where, it's like, well, lots of people have a knock to the head and they're kind of fine, and you'll be right. And maybe it's an Aussie thing, she'll be right.
It's because it's all over the world, so no.
Yeah, I imagine it's everywhere, right? And hence why humans are so adaptable.
Yep.
But what do you think needs to happen to turn the ship around?
Yeah, I like what you said then, the comparison with mild traumatic brain injuries and concussive syndrome, because it's very similar in the when it's mild, it's very similar to the level of severity we're talking about. But yet in some people it has a huge impact on their lives. Anyway, so I think the cultural shift is happening. It's happening through the dementia advocacy group. And so that's why in HIV I'm trying to kind of bring the two together, because it has happened there. They've done so much work it's absolutely mind-blowing. The community, the patient themselves, they've got so much work. They do so much work they've done, and they continue to do so much work to destigmatize mild cognitive deficit, destigmatize dementia in general and early dementia. People can still do a lot. There's a lot of resources on the Dementia Australia website, for example, that people can have a look at. Same with the Alzheimer's Association. And one of the research that has been done as well is to say it's about should we disclose cognitive deficit, as a care professional. And a lot of the professional association are all for early disclosure based on the patient and community, research and advice and input. But one thing that always come back is that this has to be done in a supportive care system. So disclosure for the sake of disclosure is going to hurt more than the good. Okay, so and so I've got a colleague in the UK. Again, it's still the UK, but he's developed this I guess HIV and aging clinic called the Orange Clinic, and that's really the feedback that is got from the community and the doctors. They are keen to look at things early and to engage into an early intervention framework, but it has to be done in a supportive care system where the different pathway to care already exist. So you're in a GP clinic, okay? So you experience mild cognitive deficit because X or Y condition. The GP knows where to send you next. It's not an act of guessing. It's the care pathway are already established, and it's an ideal care system where there's a lot of preventative a mechanism that are already, or strategy that are there, but that's what makes a massive difference. And
But I
those
can certainly
clinics already
see.
exist. Sorry.
Yeah, I was just saying, I can certainly see the value in disclosure, because that in and of itself does begin to change the culture. Because the moment there is disclosure, then as a patient, we all want to know more. We want to know
Yep,
what are the guidelines, what assistance is there out there, what can I do myself, how can
that's
I
it.
go out and get further testing.
That's it.
We are all then highly motivated to be part of that conversation.
That's it.
And obviously, I think there's a medical imperative that we do disclose any findings to patients. There is naturally an importance about how disclosure is done, so that people can understand that, we're not saying that this will happen, but we are saying that there are correlations, and as a starting point, it would be important to do some further testing, and there is support out there, and here are some of our avenues. It may not be the case, but like a lot of things, we'd be foolish not to go out and examine it. Like your leg might not be fractured, but let's go get an x-ray just in case.
And then, so I think the other aspect, so I talked about the importance of the community, in changing, doctors' mind. Really, that's what also happened early in HIV, actually. So that's interesting. We're coming back to that, but I think the other aspect is all the research that's currently being done about prevention of cognitive change as we get older, and it does work to a certain extent. So it's not going to be a magic pill again, okay? But there are a lot of healthy behavior that people can have that will help, maintain a good cognitive health as we get older. And so there's this other aspect as well, is that it's a early detection framework and also a prevention framework as well, to some extent. Yeah.
And that's very powerful if it is a cultural conversation that we're having, because I'm assuming a lot of the guidelines would potentially also be beneficial for other cognitive problems or other conditions per se.
Usually they
as
crisscross,
someone ages, there's many things that overlap. We are an organism that is incredibly complex, and doing one thing doesn't just target your memory or capacity to learn new tasks, or any of the other decline markers that we could look at. Yeah, our bodies are affected across the board, so it's very complicated. So
and then I think
a great value point there.
And then if people start to develop, clinically significant changes, again, there are a lot of things to do. So if people are ahead of the what's potentially happened to them, they're empowered, they're already informed about what to do, and then they will be typically aware of where to look for the specialized services and care that are needed for the particular condition. So that includes actually a lot of information from the patient organization. They're absolutely amazing. They do so much work, and they have a lot of good information there, on guiding where people should go, etc., etc. So again, it's not a magic pill, but it's a way of avoiding, at least in old age, I'm saying, avoiding, going through a very difficult part of your life, isolated and not knowing what's happening to you.
Well, said, it's absolutely amazing to be able to talk to you and have you as, a force out there that is using, not only research, but, data and human life examples to go out and say, this is really important, because this does not just go out and affect, HIV or COVID, even though these are great examples. All of these post-viral infections, pose a similar things, and we're certainly going to see a lot more of those in the future. Where can people find out more if they wanted to, continue this conversation, whether it's about your work, whether it's about some of these guidelines, whether it's about where the research is going? Where might someone continue?
Well, I think research regarding HIV. So I guess we're trying to develop that new website that's going to be an international website, but it's in the it's being built at the moment. But I guess if people want to know more about my research, you can always go on the UNSW University of New South Wales website and they find me there. There's also the Uprise website where there's all the research that we do about long COVID.
Mm-hmm.
And the other website that I was thinking of, well, I guess the website of the Kirby Institute would be also where people can find what I do, and they've got links to the different papers that I've written. So that's one way. But I was saying, oh yeah, and then for the HIV community, I think there's a lot of things that have been done with the community organization with who I work. So NAPWA, the National Association for People Living with HIV Australia, Positive Life, and Positive Life exists in Victoria, New South Wales, and Queensland. And I hope I'm not forgetting someone, otherwise people can be cranky at me. But they've got amazing resources. So if you HIV positive and you're listening to that, and again, the long COVID story, look at the Uprise website, Uprise, APPRISE.org.au, so you can find some information on that. And as our progress, there's going to be more information in the future.
Absolutely fantastic. I think great resources that I think branch out to a lot of other areas, and I'm assuming they're all going to be developing and putting up updated knowledge as it comes about. So it's great to know that medicine and research like yours is starting to look, I think, more of that nuanced space where we're going to look further than just the chronic. I think when it's chronic, sadly, it's not reversible for many situations, and I think all of us are very invested in whether it's early intervention or just early, what am I able to go out and do. And one of the blessings that we have in living in a first world country is that we have not everyone, but a lot of Australians have the capacity to think about their well-being earlier in life, and that's a blessing that we can take advantage of. And your type of research, I think, speaks to that, and I'd like to think that as countries develop and technology reaches other parts of the world, they can also take advantage of the work that we've already done, when those luxuries reach them. So I see this as being incredibly important, and thank you immensely, and appreciate your time and your work and your contributions.
I just want to add one or two websites. So I mentioned Dementia Australia.
Mm-hmm.
For people who I've got a question about that. There's a lot of amazing resources on that. Okay. The Alzheimer Association is great, and then my collaborator here at UNSW called Professor Karen Anstey, who's the head of the Aging Future Institute at the UNSW, with who I collaborate. So we're trying to do a dementia prevention program together with Professor Brew at St. Vincent's. It's early days, but bringing all that research in, trying to detect things early and manage early. So that's all other resources there.
No, lovely. Happy if you would like to, you can also send through any of those links, and we can attach to our podcast notes for anyone that's interested. They can click on those. But I think they're our primary national bodies and the like, so it won't be too difficult to find. Lucette, really thank you again. Really do appreciate your time, and I wish you all the best in continuing research and continuing to also put those very difficult links links together. And I hope that our culture, our community, can continue to change and evolve. I think it's quite positive in nature that this conversation is even taking place. Obviously, there's people like yourself who are interested, and lots of others out there who are living with these conditions who have a voice as well. So thank you.
Thank you very much.